So today I'll be talking on MHT, changing scenario, new HRTs also, a hope for millions of menopausal women. The menopause strikes early in Indian women at an average age of 46.2 years, and the average age in India is 70.3 years. So about 25 years of her life, she silently suffers in estrogen deficiency and menopause distress. So what we have to think of, right MHT or HRT, the choices available for Indian women, newer entrants, and making a right choice. Hormone therapy now is having more clarity to the role for alleviation of symptoms, for prevention of diseases of aging, and compression of morbidity in middle life. We all know that whenever a patient comes to us in perimenopause or menopause, regardless of her presenting symptom, we have to do a very detailed clinical examination with a detailed history, examination, taking in view the patient as a whole, presenting at perimenopause and menopause, and having an idea that yes, we have to take care of a menopause also. This list of investigations is a must for this age group, apart from all other investigations. And then MHT has to be individualized and tailored according to the symptoms, need for prevention, need for the personal and family history, comorbidities, results of investigations, and women's preferences and expectations. The management plans can be divided into two groups. One group, women without menopausal symptom, to whom we will offer lifestyle management, calcium and vitamin D. And the group 2, where the women are having symptoms, they can be divided into risk with risk factors and without risk factors, and the schedule will be different in both the groups. So MHT the risk can be minimized and the benefit can be maximized with a right choice of prescription. Prescription writing for menopausal women, we give a continuous combined estrogen plus progesterone therapy. I'll come to the details. This is the schedule, a continuous estradiol 1 milligram and dydrogesterone 5 milligram to be given continuously. The progesterones at present date, which are recommended, are only two: dydrogesterone 5 to 10 milligram or micronized progesterone 100 to 200 milligram. This is common with all the estrogens to be prescribed. And the estrogens, we have got a broader spectrum: conjugated equine estrogen 0.3 to 1.25 milligram, 17 beta estradiol 1 to 2 milligram, estradiol valerate 1 to 2 milligram, and transdermal 17 beta estradiol 25 to 100 microgram. We can see that estrogen is having a broader spectrum although, but the most recommended one is 17 beta estradiol. Tibolone again is there in the list. So it can be given up till 10 years of menopause or 60 years of age. This is very true. For vasomotor symptoms, we have just heard Dr. Pushpa. If MHT is contraindicated, we have to go for SSRIs and SNRIs, and paroxetine 7.5 milligram has been recommended. Now the question is, can the MHT push her into becoming diabetic? And the answer is no. MHT may help preventing diabetes in almost 20% of women receiving it. For type 2 diabetes mellitus, yes, it can be given. It may rather improve glycemia. The route is important. If it is oral, if they do not have any CVD risk, and it should be transdermal if they are obese or they have moderate CVD risk. So what about hypertensive patients? Can we give them MHT, and if MHT, what type of estrogen, and what the estrogen is questionable, and then it should be oral or what preparation, and if it is transdermal. And the route, we can see that MHT would be expected to leave the blood pressure unchanged or to actually promote a blood pressure reduction in postmenopausal women who are hypertensive. And the important thing is the route. It is the transdermal route which should be given. Transdermal estrogen has neutral effects on triglycerides, C-reactive proteins, and sex hormone binding globulin as against the oral estrogens, which may cause increase in the level of inflammatory markers like C-reactive proteins. For surgical menopause, what is the regime? Routine hormone therapy is not recommended for surgical menopause in postmenopausal women as primary prevention for chronic conditions if they are beyond 50. But yes, if they are below 50 MHT has to be given because it brings about benefits to the verbal memory and it improves the quality of life by improvement in sleep and mood. Prevention of osteoporosis in women with risk factors for fracture, yes, MHT is to be given. What is the treatment of choice? For perimenopausal, it is cyclical and monthly sequential estrogen plus progesterone. And for postmenopausal, it is estrogen progesterone therapy continuous. This is the continuous regime I have already shown. The guideline is the MHT is appropriate first-line therapy for women under the age of 60 with increased risk of fracture. And the effect declines when it is stopped. So we have to shift them to bisphosphonates. But it is not recommended after the age of 60 for the sole purpose of prevention of fractures. Evidence says that HRT is effective in the prevention of all osteoporosis-related fractures, even in patients at low risk of fracture. For genitourinary syndrome, we know that the effective one is the local estrogen, and it can be used daily for 1 week to 2 weeks, then bi-weekly for 3 months, and this treatment can be continued up to 1 year. The other indications, the vaginal symptoms, recurrent UTI, overactive bladder, vaginal surgeries, pre and post, it can be given. The advantages of this local is that it avoids enterohepatic circulation, there's no endometrial stimulation, no progesterone is required, no systemic side effects. It has got mainly local effects. The preparations available over here, conjugated equine estrogen and estriol creams. If there is a surgical menopause below 40 and the patient is also having cardiovascular risk, then there are two issues. One is premature surgical menopause, where it is mandatory to give MHT, but what about serious risk? And for this, what we do is that the estrogen part has to be given in the form of patch or gel. Gel is available in India. For breast cancer survivors and vasomotor symptoms, oral MHT is contraindicated. SSRIs, SNRIs, and gabapentin are the choices. Urogenital symptoms for them, local estrogen or ospemifene. Local estrogen also after consultation with the oncology team. Ospemifene is not available here. These are the various products I have already told you. Then for sexual dysfunction in breast cancer survivors, lubricants, moisturizers, if they are not working, then we can go for vaginal creams of beta estradiol, estriol cream, and equine estrogen cream. Vaginal ring of 17 beta estradiol to be changed once in 3 months, or ospemifene 60 milligram per day is a non-estrogen term, but it is not approved in US, and Europe has approved it for breast cancer treated patients. But both of these are not available in India. MHT use after ovarian cancer, a blanket statement cannot be given that all treated ovarian cancers can be given, but then prior epithelial cancers, except advanced serous and endometrioid types, then germ cell tumors and borderline tumors, yes, it can be given. Others, there is a paucity of evidence. For endometrial operated cancer operated with menopausal symptoms, if it is a low-grade, early stage 1 which have been treated, may consider MHT, others we don't give. For Turner syndrome, yes, Premarin for initial 6 months, and then estrogen plus progesterone cyclical is advocated. To stop MHT, you can stop it abrupt or tapered. In my opinion, I would like to stop it in a tapered form. What has changed is oral ospemifene 60 milligram for dyspareunia associated with the vulvovaginal atrophy has been approved. Oral paroxetine 7.5 milligram for bothersome PMS has been approved. Oral conjugated equine estrogen 0.45 milligram plus bezidoxepine 20 milligram to manage VMS and prevent osteoporosis in women with uterus has been approved, but this one is not available over here. So we have to have a checklist manifesto for right MHT or HRT. And for this, we have to choose right estrogen, right progesterone, right dose, right regime, right duration, and right route. The available options in India for estrogen are CEE, estradiol, valerate, 17 beta estradiol, oral or transdermal. Progesterones, we have dydrogesterone, micronized progesterone, MPA, levonorgestrel. Evolone is there. Then combination of E and P is now available over here since 2019, and market is having it now. The sequential 17 beta estradiol 1 milligram plus dydrogesterone 10 milligram, and continuous 17-beta estradiol 1 milligram plus dydrogesterone 5 milligram. SERMs, basidoxifene plus CEE and ospemifene, they are very good. They are not available in India. A word about SERMs. Basidoxifene it brings about improved BMD and reduces fracture risk, improves the VMS and VVA. There is no risk of severe breast, but not available. Ospemifene is a third generation SERM and is approved to treat dyspareunia associated with VVA. Again, it's not available over here. Then we are having combination of 17-beta estradiol, hemihydrate, and dydrogesterone. It is the natural choice, mimics the physiological hormones, and it is available in India. So to start with the right estrogen is one which will have a lowest liver load, no liver load, and there's no risk of VT stroke. And for this 17-beta estradiol takes over on estradiol valerate and conjugated equine estrogen. Then we come to the right progesterone, and there is a difference in various progesterones used in the hormone therapy. One size will not fit all, and but there are which fit all the sizes. If we look at this list of progestrogens, they have progestrogens have a protective effect on the endometrium, but with synthetic progesterones, there is increased risk of CVD, VTE, stroke, and breast cancer in comparison to natural ones, that is dydrogesterone and micronized progesterone. And after WHO trial, we have seen that the wing which was having CEE plus MPA had more cases of breast carcinoma than the wing which was having only estrogen. So the MPA was said to be the culprit. It is not lipid friendly also, and it has become from hero to zero since then, because it does not bind to the estrogen receptors but acts as an anti-estrogen and dilutes the beneficial effect of MST on coronary outcomes. These international bodies, IMS 2016, MAR, NICE, and ACE, they all say that the risk may be lower with dydrogesterone or micronized progesterone than with the synthetic progestrogens. So what about VTE, stroke, and CVD? Again, the same bodies, they say that transdermal estrogen less likely to produce VTE, stroke, and CVD. So it is the difference of route rather than the MST. Choosing the right dose, I've already told you. The sequential one, having 1 milligram of E2 and 10 milligram of dydrogesterone is for perimenopause and POI cases, and for post-menopause, a slightly lower dose, 1 milligram E2 and 0.5 milligram dydrogesterone in the continuous combined form, and it is available now. Then we come to the right regime, and the right regime is sequential estradiol dydrogesterone. It has got endometrial safety profile and regularized bleeding pattern for perimenopausal and POI, and for postmenopausal, the same combination in a lower dose has got a good safety and bleeding profile. Tibolone, a word about it. It is good. It has got very good effect for decreased libido, and but there is a big but. Lipid profile. It is going to cause decreased HDL and increased LDL. For stroke, it is having more risk. Weight gain, yes, it brings about weight gain. Abdominal discomfort, yes, it causes flatulence. So for a long-term treatment with tibolone is not a great choice. Then coming to the right duration. The right duration is to be individualized, and it is the key for recommendation for all guidelines. Below 40 years, MST is mandatory till the age of natural menopause. 40 to 50 years, benefits would exceed risk. 50 to 60 years, benefits would exceed risk. And more than 60 years, risks can be more. So then a word about MST and CVD risk. It is the timing hypothesis. If it is started in the perimenopausal or early postmenopausal period, then it is cardioprotective. But if it is started 10 years after menopause, it will increase the risk of CVD. So early initiation of MST reduces the risk of CHD, fracture, and all-cause mortality. We can see the list of benefits with MST, reduces VMS, VOS, osteoporosis, fracture, osteoarthritis, CVD below 60 years, risk of type 2 diabetes, abdominal obesity, cognitive impairment, neovascular macular lesions, reduces the risk of colorectal and endometrial cancer, and overall improves the quality of life. But yes, the risk of MST for stroke, VTE, CA breast, and CVD in more than 60 years has to be taken care of, but it is rare with dydrogesterone and micronized progesterone. And the important part is if you change the route, it will become beneficial. So the right route is mostly oral, but for increased risk cases, the transdermal route will be better.
Ma'am, please 2 minutes.
Yes, I'm concluding. Patient is symptom. We have to take care if the patient is symptomatic or asymptomatic. For asymptomatic, only the lifestyle management. For symptomatic, we have to have give MST. If symptomatic, does she have any risk factor for prescription of MST? We have to look for it. Patients need a complete assessment before prescribing MST. MST is safe till 60 years or 10 years after menopause. If the risk factors are present, then MST has to be according to the safety profile. So the bottom line is MST isn't all good or all bad. The guiding principle is the right estrogen, right progesterone, right dose, right route, right duration, and that will bring about a very good prescription of MST and a good quality of life to the patients. Thank you. Thank you for this.